we already completed the first level of faculty development program, in which you had classes on various aspects of palliative care. Today, we are planning to discuss a few patient stories through which we should apply the knowledge that we have obtained from the previous session. That's what the plan is. So, Sangeet will be presenting, or Sangeet will be showing us the patient stories, and then we would discuss each of the pain scenarios. But I request all of you have to get involved in this. Only then we will move forward. So, Sangeet, can you please? Yeah, this is the first patient story. So, can somebody read it for me?
Yes, good afternoon, everyone. Case 1, Mr. Ravi, 55 years old, is a shopkeeper with a 10-year history of diabetes mellitus. For the past 3 years, he has had burning and tingling pain in both feet, worse at night. He describes it as walking on hot coals. He sleeps poorly and feels exhausted during the day. He takes painkillers irregularly and has not been monitoring his sugars regularly. His HbA1c last month was 9.2. He admits feeling helpless and frustrated that no medicine works. He is otherwise active, but says the pain limits his daily routine and walking. The discussion questions: how will you assess and classify his pain? What are the pharmacologic and non-pharmacologic strategies for managing diabetic neuropathy? How will you set realistic goals and motivate Mr. Ravi for long-term adherence?
Thank you, Dr. Anil. So now I would, can I request all of you to please switch on your videos if possible? No. So we have to discuss the first question. How will you assess and classify pain? Can somebody discuss that? How are you going to assess? And also after the assessment, how do you classify his pain? Any of you can unmute and speak. Yes, Dr. Anil.
Sir, this is more like a neuropathic pain because the pain is having burning and tingling on both the feet, which is worse at night. So it looks to be more of a neuropathy. Diabetes, it is uncontrolled. The HbA1c is 9.2, while our target is usually less than 7 or 7.5, depending on the comorbidities of the patient. So HbA1c is not well controlled. The peripheral neuropathy is the most important thing. Now we have to think whether there is B12 deficiency. If he's vegetarian and if he's taking metformin, there's a possibility that he may be having vitamin B12 deficiency. So we may need to investigate for vitamin B12 level, go through the drug history, whether he's on insulin or any other medications. That would be first thing. Classify severity of pain. We can ask him on a scale of 1 to 10.
Okay.
And since his sleep is also affected and the pain is unbearable, we have to start. First thing is control the diabetes mellitus, supplement with vitamins, especially B12, maybe injection of B1, B6, and B12. And the diet control, refer to a dietitian, review his diet patterns, and revise the diet accordingly. Some physical exercise, and in addition to that, we may give some drugs for reducing the pain, like gabapentin or pregabalin. The realistic goals we can set like a target of HbA1c to be less than 7. We need to look at his height and weight and calculate BMI. If he's overweight, we need to reduce the body weight also. We need to check about dietary habits. spacing of the meals, small frequent meals instead of large meals, and frequent monitoring of blood sugar initially, and then it may be done weekly depending on what is the blood sugars, and physical activity 30, 40 minutes. So lifestyle modifications, stop smoking, tobacco, alcohol if he's consuming that. That's also important part of history. So if he's taking alcohol or smoking tobacco, we need to stop it as much as possible. For stopping smoking, we can advise to take chewing gum of nicotine for some time initially. And we need to assess for ischemic heart disease, peripheral peripheral neuropathy, and peripheral vascular disease. We need to look at ankle brachial index also. If ankle brachial index is less than 0.9 or 0.8, we need to look into vascular supply and consider for angioplasty of the vessels of the lower limb. We need to look into the cholesterol lipid profile of the person. If the lipids are deranged, we need to think of starting statins, aspirin, and clopidogrel if required. Hypertension, CAD assessment also. So it would be a comprehensive assessment. To some extent, we can give anti-anxiety, anxiolytic also to have good sleep, and counseling that it will take some time and he need to follow discipline in diet, exercise, and medication. Thank you, sir.
So thank you, sir, for elaborating this patient story. And there are a lot of points you contributed. Now I would ask other participants if they have any comments. So any of you, if you have any comments, please. Is there any difference of opinion, or do you want to manage it in some other way?
Good afternoon, sir.
Yeah, good afternoon.
I wouldn't say significantly different approach in managing the patient, but a small point would be, as his pain is most neuropathic in nature, we might use some scales that are more specific to neuropathic pain.
Okay.
Maybe like a DN4 or neuropathic pain scale when compared to an analog scale of 0 to 10.
Yeah.
So otherwise, sir has laid out a comprehensive plan for him. So only this much helps.
Okay. Thank you, Dr. Kaushik. Dr. Arya, would you like to?
Sir, as sir said, walking will be effective, but he's having pain during walking also. So then something else like some physiotherapy methods or some electro stimulation.
Okay, I understand. Okay, so if you take up the first question, how will you assess and classify pain? So first of all, we have to do the pain assessment. So in pain assessment, how are you going to assess the pain? What is the mnemonic used for pain assessment?
Socrates.
Sorry, Dr. Kaushik?
Socrates can be used, or PQ.
Socrates, yeah. So there are many mnemonics. So maybe Socrates or PQRST or PQRSTU, LDPQRST, so a lot of mnemonics. But whatever it might be, you have to understand the P means it is the palliative and provocative factors. What are the factors that is contributing to increasing the pain, and what are the factors that reduces the pain? Q is the quality. So, but here sleep increases the pain increases during sleeping. No, it is worst at night. And Q means it is the quality of pain. Here he says it is burning, and he feels like walking on coals. So that is the quality. And R means that is radiation. Is this pain radiating to any other parts of the body? No, it's only in the both feet. And S severity. Severity here. Is there severity given here? No, it says burning pain worse at night, but his sleep is affected, isn't it? And feels exhausted. So severity, we have to ask the patient this question: how much severe it is? As said previously, there are specific pain questionnaire which are related to neuropathic pain, and the usual one which we use is numerical pain rating scale in a 0 to 10 scale. And T, and that is temporal factors. So it was there for the last 3 years. It increases at night. So these all are come under temporal factors. And what is the impact of pain on this person? That is very, very important in pain assessment. Otherwise, we will look at only PQRST. So that is not enough. We have to understand what are the activities or what are the impact of this pain on this person. Because of this pain, I am unable to go to office. My income has reduced very much. I am unable to meet my friends. So I do not have any social contacts now. So a lot of things is going to affect if the patient has chronic pain. So that is what is more important. So the impact of pain on the person need to be assessed. And as you told, Dr. Kaushik said that is specific scales or tools to screen neuropathic pain like DN4 or pain detect. So those are few tools which are used specifically for neuropathic pain screening. Then we can do clinical examination to find out if there is any sensory loss. Here, the pain is on both feet. So this patient is suffering from diabetes for the last 10 years. And you can also see it is uncontrolled. So that means it is mainly a stalking type of pain, isn't it? So glove stalking is the usual pattern which happens in diabetic neuropathy. So here it's only on the feet. And you have to also look into the other factors. So once the physical assessment is over, you have to see the psychosocial aspects of the pain. Patient feels helpless. Probably he might be in depression. We don't know, because for the last 3 years he is in pain and unable to sleep, and also has poor adherence. And he is unable to do routine and walking. So those all are the psychosocial and physical impacts of this pain. And how can you say this is neuropathic pain? What are the qualities or what are the points which indicates this is neuropathic pain? Can somebody?
Burning and tingling pain, sir.
Yeah, burning and tingling. That is quality of pain. What else?
Pins and needles.
Yes, those all are qualities of pain, of neuropathic pain.
Peripheries are affected.
Sorry?
Extremities are affected.
Extremities are affected. What does that indicate?
Mainly the small nerve fibers are more involved.
Yeah. It is bilaterally symmetrical in the stalking pattern, isn't it? What else to say it is neuropathic pain?
Not related to activity.
Okay.
No history of any other trauma or anything like that, sir.
Okay.
Sir, it is the chronic in nature. It's from past 3 years.
Okay. So features of neuropathic pain includes you should get a history of either a disease or lesion affecting somatosensory nervous system. So here we have a disease, diabetes mellitus, which is going to affect the sensory nerves, isn't it? Somatosensory nerves. So that is the first thing. And then is it neuropathic pain would be in neurodermatomal in pattern. So here on both feet, so probably it has affected the fibers to the fibers to the both feet, and it is symmetrical also. Then quality of pain. Quality is it's burning. Then the pain can be either there can be more pain or can be reduced sensation. So here he feels like walking on hot coals. That means maybe he is describing allodynia. And so allodynia and hyperalgesia, these are some pointers indicating that it might be neuropathic pain. So these are the points by which we can say this might be a neuropathic pain. And probably from this history, we understand that this is diabetic neuropathic pain. Diabetes causing neuropathic pain. And what are the pharmacological management of this pain? How are you going to treat a patient who is having pain due to diabetic neuropathy? What medication would you use?
Control diabetes, and we can use gabapentin.
Okay. Yeah. What else?
PCS can also be used. SNRI can also be used.
Yes. So suppose we use TCA like amitriptyline. What all we have to think in this patient? What all should come to our mind if you are going to start amitriptyline for this patient?
The normal kidney functions and liver function.
Okay. More important things if you are going to start amitriptyline.
ECG.
Sorry, Dr. Ramesh.
Underlying cardiac rhythm disturbances.
Okay. Why did you say that? Because amitriptyline can produce some arrhythmias,
Yes, sir.
tachycardias. Yeah.
Yes, sir.
What else? More important in this patient, some of the side effects of amitriptyline can be more. It can produce more side effect in this patient. What are those?
So postural hypotension is one.
Yes, postural hypertension. So tricyclic antidepressants like amitriptyline can produce postural hypertension. In addition, this patient is diabetic, so we can also expect some autonomic dysfunction by which the patient is predisposed to orthostatic hypertension. So amitriptyline is going to add to that. What else?
So this may also increase appetite. Weight gain may also be there to some extent. If the patient is already overweight, obese, then this may be an issue.
Yes.
Probably. It can increase sedation, sleepiness. So it would be good for him. He would be able to sleep.
Yes.
If he's given this. So that would be
55-year-old male. So what other side effect of amitriptyline is going to be a problem in this patient? 55-year-old male. Benign prostatic hypertrophy, isn't it? And it can produce urinary retention, and amitriptyline can also produce urinary hesitancy. So that can increase. So these are few things which we have to understand when you prescribe amitriptyline. But as Dr. Anil said, it can increase the or help with the mood of the patient if there is any chronic anxiety or depression. But as he said, SNRIs like duloxetine and venlafaxine can also be used. So American Diabetic Association, they recommend duloxetine for treating diabetic peripheral neuropathy. So it can be started 20 milligram to start with, and then gradually increase and up to 60 milligram per day in divided doses. It can also help with mood. And I can see some of the chat answers in which they have described the pregabalin and the gabapentin. Those can also be used. What is the dose of pregabalin that is suggested to treat neuropathic pain? Anybody? Dose of pregabalin to treat neuropathic pain. Start with 75 milligram at night, and then gradually titrate it to, and maybe you can increase it up to 150 to 300 milligram per day in divided doses, in 2 divided doses. And gabapentin can also be used, and maybe to start with 100 milligram, but the doses of gabapentin that has been suggested to treat neuropathic pain goes up to 3.6 gram per day. So that is something which you have to keep in your mind. And the cost of pregabalin and gabapentin too, duloxetine too, compared to amitriptyline, imipramine, or nortriptyline. And if there is the responses, or if there is partial response with either of this, then you have to combine with the pregabalin or gabapentin. If you have started patient on duloxetine, later once you reach the optimal dose, you combine it with pregabalin or gabapentin. And also sometimes the pain can be so severe, and duloxetine or gabapentin or pregabalin, that is going to take some time to act to give proper pain relief. So in that case, you might give tramadol maybe for a few days, maybe 2 weeks, to get some pain relief, by which time the other medications, duloxetine or pregabalin or gabapentin, would slowly take over the pain relief part. And glycemic control is very important. Here it is 9.2%. So diet and diet modification should be given, medications and regular monitoring. All these are important. Non-pharmacological management, it includes patient education. So we have to tell the patient why the patient has pain, what is the reason for this, in a language that can understand, the patient can understand. Then the importance of food care, then regular walking, exercise for food, sleep hygiene, psychological support for the patient, behavioral activation. So this patient is not going for any job. He is not doing any daily routine or walking. So we have to gradually encourage the patient to do that. And how will you set realistic goals and motivate Mr. Ravi for long-term adherence? So all of us know that this is going to be very difficult to get complete pain relief. So you might say that pain will not disappear completely, but we should not say that. We should say that we should aim for maybe at least half, maybe 30 to 50% reduction of your pain, and so that your sleep will become better and your function will become better. You might be able to walk. This is how we have to tell the patient, because we may not be able to give complete pain relief within 1 or 2 weeks. That is not possible. So we have to set some realistic expectation. That's what we have to do. And then we can say maybe we will try to improve your sleep, maybe 5 to 6 hours continuously, and we can try to walk for 15 to 20 minutes. And to improve the adherence, we have to actually simplify the regime. There would be a lot of medications, maybe a long list. So we have to see what all are actually necessary for this patient. And it is very important to reduce the number of tablets. Otherwise, nobody is going to take 10 or handful of tablets. So it is a very common problem. Then you have to tell the patient that even though we are going to start medication, it will take some time, maybe 2 to 4 weeks for these medications to act. So till that time, the pain will gradually reduce, and we expect that within 2 to 4 weeks, you will get satisfactory pain relief. It is not complete pain relief. And we also need to tell the patient that if there is increased sugars in your blood, it is going to damage your nerves, and it can cause more pain. So that it is very important to control the blood sugar levels. And we have to explore his concerns, what he think about the medications. And how are we going to motivate Mr. Ravi? You can say that your pain is real, and it is very common in diabetes. We may not be able to relieve it fully, but we will try to make it have satisfactory pain relief. And if you take medicines regularly for a few weeks, you should feel better, not only in terms of pain relief, but also your function and walking would improve. So all these things can be told to the patient. So that's about first patient. And if there is anything else that you want to contribute, you can do it. Anything else?
Sir, how much tramadol should we recommend in these patients?
Maybe you start with 50 milligram TID.
Okay.
And the maximum dose of tramadol recommended is 400 milligram.
400 milligram, that's right.
Okay. We'll move on to the second patient. Sangeet, second patient. Yeah. Somebody can please read this.
Mr. Thomas, 52-year-old, was treated for carcinoma of tongue 1 year ago with surgery and radiotherapy. He now has persistent burning pain and numbness along his lower face and jaw on the operated side. He describes the pain as pin and needle sensation with electric shock-like burst that worsen at night. He is currently on morphine 10 milligram every 4 hours, but says it does not help this pain. He finds it difficult to chew and is becoming socially withdrawn due to facial appearance and pain. his sleep is disturbed and he feels irritable most of the time.
Okay, questions also.
What features in the case point to neuropathic pain? Which adjuvant analgesic would you consider and how would you start them safely? What additional non-drug measures could help Mr. Thomas regain comfort and confidence?
Okay. So if you want to discuss the first question, what are the features that points to neuropathic pain? Yeah.
Sir, as you earlier said, this pins and needle sensations of one dermatome is affected, and all these things corresponds to that neuropathic pain.
Okay. So here, so the first feature is that whenever you see a patient with neuropathic pain, you think whether there is a disease or lesion that is affecting somatosensory nervous system. Is there a disease or lesion affecting somatosensory nervous system in this patient? Yes, isn't it? Because this patient has carcinoma of the tongue. So probably it might be infiltrating into the cheek. So the nerve fibers can get affected. Okay, that's the first thing. And then you said burning pain, which is a feature of neuropathic pain. And then neurodermatomal in pattern. So, or the lower face in this area, isn't it? So probably one of the trigeminal nerve branch is getting affected, and so it might be neurodermatomal. And what else? Here there is no allodynia or decreased sensation. So these are the three things which is present in this patient. So those are the points which says us that it might be neuropathic pain. Which adjuvant analgesics would you consider and how do you start them safely?
The Tegretol or carbamazepine, that is one drug which can be used, or oxetol, they were being used. And in addition to that, gabapentin can also be used.
Okay.
We have experience of carbamazepine more often. We used to start with 100 milligram twice a day for 2-3 days, then increase to 100 milligram thrice a day for 2-3 days, then make it 200 BD, then 200 TDS. We go up to 400 twice a day or maximum thrice a day because it can cause sedation and difficulty in walking, unsteadiness in gait. So we increase the dose gradually and tell the patient that it will take some time for the drugs to act. So be patient with that. We can add some sedative at night so that he can sleep if required, although he's on morphine. So, but we can add some benzodiazepine and then we give a word of caution that this may cause a reaction if the he develops patches on the skin or some changes. It should be reported immediately and stopped, otherwise it can lead to Stevens-Johnson syndrome. So this is what we usually do.
Okay.
Thank you.
Thank you, sir. So, so here again, adjuvant analgesics. There are a lot of adjuvant analgesics which can be used in this patient, which includes gabapentinoids, gabapentin, pregabalin, the tricyclic antidepressants, SNRIs, and other anticonvulsants like carbamazepine, oxcarbazepine, all those can be used. But as I said, the carbamazepine is the drug of choice for trigeminal neuralgia. But here we are looking at a patient where there is more of continuous pain. And along with that, there is electric shock like burst, and that is intermittent pain. So it is usually said that if the patient has continuous pain, maybe a tricyclic antidepressant or a SNRI would be better. But if there is intermittent pain, then one of the anticonvulsants would be better. But considering the side effects of carbamazepine, as Sir said, it can cause Stevens-Johnson syndrome and many other things, sedation, um, and many other things, many side effects. So maybe we can keep carbamazepine as the second choice. We will start him on carbapenem, pregabalin, or tricyclic antidepressants, and increase the dose as necessary, and combine it with uh, what is the neuropathic pain ladder? How do you treat the neuropathic pain with a neuropathic pain ladder? What are the medications which are used in the neuropathic pain ladder? What is the first step? First step is either tricyclic antidepressants or anticonvulsants. Tricyclic antidepressants or SNRIs can also be used. So tricyclic antidepressants, SNRIs, or anticonvulsants. That is the first step. And in the second step, if there is no pain relief with optimal doses of the first step medication, then you can add one of the medication from the first step. So that means if you have started patient on tricyclic antidepressants like amitriptyline, you have reached up to 75 milligram, maybe up to 100 milligram. That is the maximum dose that the patient might be tolerating. And after that, you can add maybe gabapentin or pregabalin and titrate it up to maximum dose. So that's the second step. And the third step, it is the NMDA antagonist like ketamine. And in the fourth step, it is the interventional analgesia, maybe epidural or anything else. So that's how the neuropathic pain is treated usually. So in this patient also, like the previous patient with diabetic neuropathy, we can use the same thing here. What additional non-drug measures could help Mr. Thomas regain comfort and confidence? How can we give more comfort and confidence?
The counseling,
Mm.
reassurance that it is not going to be life-threatening.
Mm.
So it's not a recurrence of cancer per se, but it is a part of complication, maybe surgery, and some nerve endings are getting irritated. And if the drugs are not helping, then maybe local infiltration of xylocaine and something may help to some extent. And then it may increase the numbness of the part. So he may be relieved of pins and needle prick, but he may not be able to get taste on the tongue or that area. Plus regular follow-up to evaluate for recurrence of malignancy in future, if at all. But the reassurance that it is not malignancy and it's not going to affect your survival, that is one thing. And drugs will help to some extent. It may not be curative, but yes, it can come down to large extent. 50 to 75% we can expect improvement in symptoms. And if possible, we can have some social group of patients who are having cancer. So if they interact with same patients with similar cancer tongue or this thing, it may be easy for them to cope with them. So if that is a possible option, we can think of that.
So here you can see that the patient is socially withdrawn because of the facial appearance. So that is very important. So we have to actually acknowledge that, okay, we understand that there is an issue like this, and you are unable to attend social functions, which is real. So we are acknowledging the situation, and maybe we can take the help of the rehabilitation or reconstructive surgery people, if there is anything can be done for that. And maybe counseling, and as I said, support group is another important source from which they can learn each other. What is the strategy the other people have been used in such situation to overcome this phase? So support group is very, very important. Then maybe we can suggest soft diet, dietitian referral, jaw exercise. All these are important because the patient is unable to chew because of maybe due to pain, or maybe there is some stiffness. All this might be contributing to the poor swallowing and chewing capacity. Yeah. What else do we need to discuss in this patient? So it's just like a neuropathic pain. The only difference from the first patient story is that here this is due to malignancy, and it is causing a lot of psychological and social, probably spiritual distress to this patient. So in addition to the drug management, medicine management, we have to also address the psychosocial and spiritual factors. So whenever we look at the pain, we have to see the total pain of the patient. Pain is not only physical, because the other components, the psychological, social, financial, spiritual issues, these are going to affect the physical pain. So it is very important for us to address the total pain. Okay, we will move on to the next patient story. Somebody please read this.
Good afternoon. Am I audible?
Dr. Shivagami, you are audible, but volume is very less.
Mrs. Leela, 65-year-old, has metastatic breast cancer, spinal and pelvic bone deposits. She has been on oral morphine 10 milligram every 4 hours for the last 10 days. Her background pain has reduced significantly, but she experiences sudden intense pain in her lower back and right leg 1 to 2 hours before the next dose, especially when getting up from the bed. She started to avoid moving because she fears the pain. Her daughter reports that her mood has become low and she feels the medicines are failing. So what type of pain is Mrs. Leela experiencing and how will you confirm it? How can her morphine regimen be modified to address these breakthrough episodes? What patient and caregiver counseling would be essential in this context?
Okay, thank you. And would you like to discuss the answers? Or anybody else?
Her anxiety-induced pain, no?
Is it anxiety-induced pain? What do you think? She has metastatic breast cancer with spinal and pelvic bone deposits. She has been on oral morphine 10 milligram every 4 hours for the past 10 days. Her background pain has reduced significantly, but she experiences sudden intense pain in her lower back and right leg 1 to 2 hours before the next dose, especially when getting up from the bed. What does that indicate?
Sir, it could be due to the compression of the cord, or the bone pain component can be there.
Okay. What is it called as? What is the general category of that type of pain?
So neuropathic pain.
That is specific type of pain. I am asking. The patient experiences pain 1 to 2 hours before the next dose. What is that?
Breakthrough pain.
Sorry? Yeah.
Breakthrough. Breakthrough pain.
It's a breakthrough pain. It's a type of breakthrough pain. And you can say it is end of dose failure pain. End of dose failure pain. So the pain which appears maybe an hour or two before the next dose. This happens with each dose. You are giving morphine at 10 a.m. By 12, patient complains of pain. And when you give 2 o'clock, the patient complains of pain by 4 o'clock. That means it is end of dose failure, because the dose that you are giving is not sufficient. That's why the patient is experiencing pain before next dose. So that is known as end of dose failure pain. Okay. And she also says it is this pain comes especially when getting up from bed. What does that indicate? What is the type of pain with movement? What do we call that type of pain? It is incident pain. Okay, incident pain. Pain which comes on movement is known as incident pain. So this patient has breakthrough pain, or in other words, more specifically, incident pain and end of dose failure pain. So we have to get history. We have to ask Leela or her caregivers. Possible. We have to ask actually to the patient, because patient is the one who is experiencing this. So you have to ask Leela, does this pain comes before the next dose when at each time? And also regarding incident pain, whenever you wake up or from the bed, getting up from the bed, do you experience pain? That is pain on movement. How can her morphine regimen be modified to address these breakthrough episodes? What are you going to do with the dosage of morphine in this patient to address the pain?
So we can increase the dose to 15 milligram initially, every 4 hourly. And if it is not causing sedation, drowsiness, and the pain persists, we can increase to 20 milligram. And if he's not able to sleep, we can give 30 milligram sustained release at bedtime, along with a laxative. I'm sure she would be already getting that laxative. We may have to increase the dose of laxative.
Okay.
And we need to look at the MRI of the spine, whether there is nerve compression also in addition to this thing. So if there is a nerve compression, we can add adjuvants like duloxetine or TCA kind of thing, if she is not on these drugs already. Or if there is evidence of inflammation, we can give some NSAIDs also, like ibuprofen. If there's edema or pressure, we may have to think of giving steroid also. These are some of the thoughts.
Okay, thank you, sir. So we have to actually increase the dose of morphine. How much morphine are you going to increase? You can increase 25 to 50% of the previous dose. So from 10 milligram, you can increase it up to 15 milligram. As I said, maybe you increase it up to 15 milligram every 4 hourly. And maybe if the patient experiences breakthrough pain, even with increased dose, you have to give SOS dose of morphine. So SOS dose would be, if you give patient 15 milligram 4 hourly, the SOS dose would be how much?
15 milligram.
It would be 15 milligram. Whatever be the regular dose of morphine, that is the SOS dose that you are going to give to the patient. And maybe steroids might help in this patient because she has spinal and pelvic bone deposits, and we don't know whether that is causing any spinal cord compression or nerve root compression. We don't know. So if it is so, if there is any nerve root compression, steroids would also help. But in addition to that, you can also give the bisphosphonates or radiotherapy. That's another important thing which you have to think, because a bone pain would be responding better to radiotherapy, or even the bisphosphonates, which are osteoblast inhibitors. Bisphosphonates like zoledronic acid, those also can be used, which can also reduce pain, but it will take time. What patient and caregiver counseling would be essential in this context? What are you going to talk to this patient and caregiver?
So this is advanced stage of malignancy. Already metastasis have happened in the pelvis, and so now we need to focus on palliative care more than the curative one, and focus on quality of life. So what are the patient wishes, what expectations, and how much we can fulfill. So if patient is in good state of mind, advanced directives kind of thing may be discussed. If patient is mentally prepared for those things. It doesn't seem that she will die in next few days or weeks. Weeks may be possible, but not in few days. So we need to start looking into this part of care.
Okay. Yeah. So what counseling is the question, and we can see that her daughter reports that her mother's mood is low, and she feels the medicines are failing. So the mother and the daughter, they are thinking medicines are failing, but then you have to tell them that her background pain is controlled, but the sudden pain which comes due to this bone deposits, that would require extra dose. So it is not because the medicines are failing, because the medicine which she is taking is not enough to control the pain. That's all what is happening. This is something which you have to tell the patient and caregiver. And you have to also describe the patient what is breakthrough pain in her own language. And we have to also tell the patient to take rescue doses or SOS doses. And she is afraid to move. That is something which you can see. So we can tell her that you have to move, but maybe before that you have to undergo radiotherapy, which will strengthen the bone so that you can move easily. So the importance of radiotherapy is something which we have to talk to the patient and caregiver here. And maybe we can also set some realistic goals about function in this patient. Sitting up with less pain, walk for short distance, and improving sleep. All these are important in this patient. And as we said, the total pain has to be taken care in this patient too. She has low mood, she has fears, loss of confidence. So all these need to be taken care of. And the caregiver can be taught when to give rescue doses, when to expect pain, uh, and when to report about the pain to the treating doctor. Yeah, I think these are few important points that we need to tell the patient and caregiver. Okay. Next question. So it's the fourth patient story. Can somebody please read it for me?
Mr. Arun, 58 years old, has carcinoma of the lung with bone metastasis involving the spine and ribs. Over the past 2 months, his back and shoulder pain have worsened, described as a continuous dull aching with occasional sharp episodes of movement. His pain score is 8 by 10. He is currently taking paracetamol and tramadol prescribed by his local doctor but finds little relief. He sleeps poorly due to pain and wakes up multiple times at night. His appetite is poor and has lost 3 kgs in the last month. He's anxious about using morphine as he has heard it causes addiction. His wife is distressed seeing him in pain. The discussion questions: one is, how will you assess and document his pain before initiating opioids? And how would you introduce morphine? What dose, schedule, and patient education would you provide? What non-pharmacological or supportive measures would you consider in this situation?
Yeah. So would you like to discuss the first question? How will you assess and document his pain before initiating opioids? We already discussed this.
So, sir, the pain score is 8 by 10, and he's taking the paracetamol and tramadol. That is the step 2, and he's not relieved with this. So, we have to add the strong opioid. So, we can omit the tramadol and increase the and add the morphine to this patient.
Mm. Okay, thank you.
So,
Yeah, please go on.
so we can start the morphine 5 milligram, and but he's taking the tramadol, so we can titrate dose as per he's taking the tramadol, or we can start from 10 milligram 4 hourly.
Mm. Okay.
Sir, if it is introduced for the first time, isn't it like we start with 5 milligram 4 hourly? And if the pain does not improve, then we increase the dose, whether patient becomes drowsy, sedated or not. So, since patient has not received morphine earlier, so I would like to start with 5 milligram.
Okay.
Or
Okay.
should we give injection morphine 1.5 milligram, repeat after 10 minutes and see, because the pain is 8 by 10, although it is not 10 by 10, but even then it is distressing, and then see how much dose is required to relieve the pain.
Yeah.
And then we switch to oral.
Yeah. Yeah, that's a good thought because the patient has severe pain, and you want to see whether the pain responds to morphine and also the dose required by giving a IV morphine titration. Yeah, that can be done. But otherwise, you start with 5 milligram every 4 hourly with SOS dose. So, how will you assess and the first question? How are you going to assess and document his pain before initiating opioids? We already discussed, isn't
Follow
it?
PQRST.
Yeah, the PQRST and the impact of pain on the person. And what is the type of pain here the patient is experiencing mostly?
Is it nociceptive?
Yeah, it is mainly nociceptive pain. Carcinoma lung with bone metastasis involving spine and ribs. For the past 2 months, his back and shoulder pain have worsened, described as a continuous dull ache. Okay, continuous dull ache with occasional sharp episodes with movement. It is not of movement. So it is mainly continuous dull aching pain, which is characteristics of nociceptive pain. So you can go with the PQRSTU, then the psychological issues, social and financial issues, spiritual issues of the patient. How do you introduce morphine? We already said that we can start with 5 milligram Q4H if oral morphine is the only available thing with you. But if you have injection morphine, you can give an IV morphine titration and find out the dose which is required to relieve the pain. Okay. What patient education would you give here?
So patient education that in the dose what we are prescribing for pain is not going to be addictive. So there is no risk of addiction and be comfortable. And it can cause constipation, so you need to take a laxative along with it regularly. And Visacodil is usually recommended 5 to 10 milligram daily. If required, we can add a little husk or some kind of softener, stool expander, and then softener also if required. Do for like lactulose kind of thing if required.
Okay.
And the medicine has to be taken every 4 hourly so that the effect is maintained and you have minimum of symptoms. And SOS dose if the pain occurs in between. If there's no improvement, we do follow up in 5 to 7 days time.
Okay, thank you, sir. So many of the important points came up here. The main thing is that the patient is anxious about using morphine. As he had, it causes addiction. So that is something which you have to address. Otherwise, the patient will not take morphine. So you can tell the patient that when morphine is used for cancer pain in such smaller doses under medical supervision, the chance of addiction is extremely rare. So that is something which you have to tell the patient. And you have to also tell the difference between the addiction and physical dependence. Where addiction is psychological dependence. And physical dependence, when you continue to give some medications like morphine, maybe after 1 or 2 months, when you stop it suddenly, the body will react to it. That is known as withdrawal reaction. That indicates the patient has physical dependence. But if the patient has psychological dependence, then that is known as addiction, where the patient would be craving for the drug. And there would be a lot of other behaviors which indicates the patient has addiction. So mostly what happens is people understand that whenever a medication is stopped, the patient has some symptoms which is indicating addiction. That's what people think, and they don't know the difference between physical dependence and psychological dependence. So this you have to tell the patient. And also, it is important to tell the patient that why morphine is needed here. So what are the present medication? It is paracetamol and tramadol. So you have to tell the patient that tramadol is something which is given for moderate pain, and you have severe pain which and tramadol would not give much relief for that pain. And morphine is the gold standard for treating such pain all over the world. And also set realistic expectation, um, how much pain would be reduced, and what would be the type of sleep you are going to get. All those things can be discussed. What are the additional supporting measures or non-pharmacological measures you would consider in this patient? Maybe proper positioning of the patient, supportive mattress, and gradual mobilization. And how to reduce the nighttime awakening, how to improve the sleep hygiene has to be followed. So all these things are the non-pharmacological measures, then psychological support for the patient. Yeah, I think those are a few important points which we have to tell the patient, or in the non-pharmacological management, that is what we have to give to the patient. Do you want to add anything else in this patient? Once morphine is started, how frequently you have to monitor the patient? Or if possible, suppose the patient is admitted, when would you review this patient?
So if patient is admitted, we may review every 4 hourly. So that
Yes.
we need to decide the next dose should be same, or patient is requiring SOS dose, or is there any need to increase, or whether patient becomes drowsy in between.
Yes, but when would you plan to increase the dose, if that is necessary?
If the patient says the pain is 8 or 9 or 10, then we have to add SOS. And if a patient requiring maybe 2 extra doses, then we need to think of increasing the dose.
Yeah. So every 24 hours, actually, you can increase the dose of morphine. So if you want to increase, you started a patient on 5 milligram today, and you see that this patient is taking more SOS dose, or if the patient does not have satisfactory pain relief, then next day you can actually increase the dose. Yeah. We can move on to the fifth patient story. Yeah, some of you can read this. Anybody?
Sir, Mrs. Fatima, 48-year-old, is living with advanced ovarian cancer with abdominal mets. She reports severe abdominal pain, rated 9 by 10, despite being on regular morphine and laxatives. When generally explored, she reveals deep worries, her teenage children's education, her husband's financial stress, and guilt about being a burden. Her nurse notes that Mrs. Fatima often cries alone and refuses to meet visitors. Her pain seems worse when she is anxious, but slightly better when her sister stays with her. How does this concept of total pain apply to Mrs. Fatima's situation? How would you address the psychosocial and spiritual components of her pain? Which member of the multidisciplinary team should be involved, and what would their roles be?
Okay, thank you. So, what is total pain concept? Somebody please tell me, what is total pain?
The physical,
No.
emotional, psychological, and spiritual pain.
Yeah. So total pain, it
Apart
recognizes
from the real pain. Sir.
yeah. So as I said, it includes all the aspects of suffering. It is not only physical pain, but includes the psychological, social, and spiritual pain. So all these together, we call it as total pain. And this concept was put forward by the founder of modern hospice medicine. Who is that? Who is the founder of modern hospice movement? It is Dame Cicely Saunders. Dame Cicely Saunders. She is the founder of modern hospice movement, and she is the person who put forward this total pain concept. Okay, how do you address the psychosocial and the spiritual components of her pain? So we have to address all the aspects. The physical aspects need to be taken care of. The psychological, social, and spiritual aspects also need to be taken care of. So you can see here, she reveals deep worries about her teenage children's education, her husband's financial stress, and guilt about being burdened. So these are the psychological issues for the patient. So we have to actually explore more about this and validate her feelings. Anyone in your situation would feel this way or feel the same things. And we have to also screen for depression because she is having deep worries. A lot of things which is going to affect her psychological health. And she says being a burden to the family. That is something which we have to explore more. So you can ask her, why are you feeling so? Are there any conflicts between your husband and or with children? So all these things need to be explored. And we have to also give social support interventions because the children's education, she is very much worried. So we have to make some plans. How are we going to support these children for education? Regarding the spiritual issues, you can ask the patient what gives you strength during difficult time. What matters most to you now? So these are something which is connected with spiritual issues. And maybe if she's religious, then we have to offer that support, cultural or faith-based support, or even the spiritual counselor or chaplain, if she wish to. You can also see that a patient is her pain seems worse when she is anxious, but slightly better when her sister stays with her. So this is another thing which we have to talk to the sister and understand more about the patient from the perspective of the sister, and also ask the sister to give more support to the patient because her presence itself making some difference to the patient. The anxiety is reduced. so that the pain would be reduced, her sleep would be better. So all these things can happen if we talk to the sister. Which members of the multidisciplinary team should be involved and what would their roles be? Who all should be involved?
So the doctor, treating doctor, and then the nursing staff, a social worker, and family members, especially sister, some neighbors if possible.
Yeah.
Because she feels better with sister, she may feel better with other friend circle or some other relatives who can visit her. So somebody can come there and visit her frequently by
Yeah.
rotation so that she gets someone to assist and help in moving around or feeding or whatever kind of help she needs.
Yes. Yeah, that's correct. So the doctor should be there to optimize the pain control. Nurse for ongoing emotional observation, building trust, reinforcing medication adherence, identify distress to the patients. So all this can be done by the nurse because she is the person who is with the nurse most of the time. It is not the doctor. And then medical social worker can explore more about the social issues, financial concerns, children's education, psychologist to manage anxiety, depression, guilt, and spiritual care provider, if present, maybe explore the meaning, hope, and dignity, support the existential distress, and family. The sister is very important because her presence makes some difference to the patient in a positive manner. So all the interdisciplinary team members or multidisciplinary team members, they have their own role because each of them can contribute to the comfort and dignity of the patient. So each member is very important. It is not only the doctor. Doctor would be looking mainly at the physical uh, problems of the patient, even though he would be able to explore the other aspects, but there would be more specialized people to explore those areas too. So working in interdisciplinary team or multidisciplinary team is very, very important for taking care of the total pain of the patient. Yeah. Anything else from this patient story? I think this is the end of patient story discussion. Yeah, we have only 5 patient stories. So if you want to tell anything else, you can.
There are no more points to discuss. Thank you, sir. Thank you for taking part in the discussion. Thank you all the participants for the fruitful discussions. Thank you. Let's see the tomorrow session. Thank you.
Tomorrow is communication. So the scenarios has
I'll
been
be sharing tomorrow is the communication topic. I'll be sharing the scenarios in the WhatsApp group, and I'll be also sharing the poll for selecting the role of the such as the doctor and the patient and caregiver.
So tomorrow we have a communication session. It's scenarios, and the whole group would be divided into 4 or 5 groups, and each group would be getting a particular communication scenario, which you have to come prepared to do that. Sangeet will be sharing that. in the WhatsApp group.
Thank you all. Let's see tomorrow.
Thank you.
Thank you, sir.